Good afternoon, everybody. For those of you who don't know me, I'm Alan Budney. I'm one of the investigators in the CTN, as well as an investigator in the CTBH. And it's my pleasure today to welcome you to the CTN Northeast Node Science Series. We have them every few months. Most of you have probably attended in the past. A couple of housekeeping things. If you're looking to get continuing education credits or CME credits, whatever you want to call them, the number is down there in the corner of the board. FFPV. Is that it?
Nope.
That's not it.
3KDB.
Forget that. It's 3KDB. I'm probably the only one in the room that needs it. Anyway, please note all that. What else do we need to take care of? Nothing there else, I don't think.
If you need a CEU certificate, please email Bethany.
Okay. Disclosures. No disclosures for our speakers today. And I guess upcoming, we don't have one scheduled to announce. All right, well, let's do it now in case we run out of time. It looks like in March, we have Dr. Trivedi, I believe from the University of Texas Health Science Center, of the Texas node of the CTN. He's going to be talking about accelerated development of addictive pharmacotherapy treatment, the ADAPT-2 trial. That should be pretty cool. Methamphetamine. We don't hear a lot about methamphetamine, but it's coming back, and it's coming back hard. So make sure you catch Dr. Trivedi's talk. All right, today we have a dynamic duo of speakers, local speakers working hard to fight the opiate epidemic. The first speaker today is going to be Dr. Letourneau from Maine. Dr. Letourneau is a graduate of Brown University in the Dartmouth Brown program in medicine. She's a board-certified internist who practiced emergency medicine for 7 years before beginning her work on what we're going to talk about today, which is public health and making healthcare happen and gaining access for people and improving care, et cetera. That's what we're all about today. Dr. Letourneau is an experienced physician leader. He's been a passionate advocate in the area of healthcare system delivery and change for many years now. Her interest in improving care for opioid use disorder, which is what today's talk is about, resulted from directly witnessing the ravages of the epidemic in Maine, across England, and elsewhere. She currently serves as Associate Medical Director for Maine Quality Counts. Maine Quality Counts is a regional health improvement collaborative. She previously served for 8 years as its Executive Director. In that role, she led the development of Caring for Maine, a statewide collaborative for engaging clinicians in addressing the opioid epidemic by improving the safety of opioid prescribing and increasing addiction treatment. Our second speaker today is going to be Jeanne Ryer. Jeanne holds a doctorate in education and a master in science. Jeanne, I don't know where they're from because they're not on my intro here, but you can fill us in if you like. Jeanne is a director of the New Hampshire Citizens Health Initiative, and that's a multi-stakeholder, statewide effort to create a system of care that promotes health, assures quality, and makes care affordable, effective, and accessible to all New Hampshire residents. From 2003 until 2011, Jeanne was program director at the Endowment for Health. That's New Hampshire's statewide health foundation, where she managed a portfolio of grants, projects, and policy initiatives that address economic and geographic barriers to health. She's worked for a whole slew, from what I can tell, of nonprofit organizations with the goal of increasing funding and access and quality health care to the residents of New Hampshire and the region. Her professional interests include population perceptions of health and well-being, building multi-stakeholder collaboratives for health system transformation. She's actually authored and co-authored several books, including one on early guides to the internet, kind of cool, and on accessing health and medical information online, which is, again, very, very important. She currently serves on the Legislative Commission on Primary Care Workforce, the New England Comparative Effectiveness Public Advisory Council, the Board of Trustees of Foundation for Health Communities, and a few other things. So you can see she's very busy promoting access to health care. So today, these two are going to speak on There we go. Using the ECHO project model to address the opioid epidemic in the New England area. So if you don't know about the ECHO project in general, you're going to learn about that, and then you're going to see how they are really leveraging it to increase knowledge, increase access, increase quality of care across our region. So Lisa, I believe you can take it away.
Terrific. Thank you so much. I appreciate it and appreciate the opportunity to share with you some of the work we've been doing. Apologize for not being there in the room, but I think with weather, we've got actually quite a few folks online. If folks haven't used Zoom before, just would encourage you to use the chat function to ask questions. We're happy to answer them either as we go, or certainly there'll be time at the end. So if we could go ahead with the slides. The idea today was really to talk a little bit about the basics of Project ECHO. I think increasingly it's becoming a term that's out there, so I suspect that of those on the phone, some of you are familiar with it and some of you may not be. So we are going to spend a few minutes just talking about what Project ECHO means, what the model is, talk a little bit about how we've used it as a tool in northern New England, so across Maine, New Hampshire, and Vermont. Talk then specifically about how Project ECHO and the model might be a helpful adjunct to efforts to address the opioid epidemic across northern New England and in other rural areas, and talk specifically about some of the ways we are using it related to the opioid epidemic. And we're just going to do a little back and forth between Jeanne and I. So go ahead. Just to start out, for those who aren't familiar with ECHO, it is actually an acronym. So it stands for Extension of Community Healthcare Outcomes, and it was started by Dr. Sanjeev Arora at the University of New Mexico over 10 years now. I should have the dates, probably closer to 15 or 20 at this point. And he has really grown it into a not-for-profit movement, and he takes very seriously this commitment to sharing and having it be an open platform for sharing of information and ideas to improve care by collaborative problem solving, basically. Go ahead, using a video-based platform, just like what we're using right now, typically the Zoom platform. The idea is as broad and as bold as having a movement to demonopolize knowledge, basically to move knowledge in what traditionally is often sort of tightly held centers, specialty care and expertise, to push that out to primary care clinicians and communities, and increasingly to non-clinician audiences as well, really to communities and different sectors and communities, in order to be able to provide best practice care no matter where one is, and particularly to serve the underserved populations and vulnerable populations. Go ahead. The idea is, again, to push knowledge from, in this model, what is typically described as a hub of specialty expertise with groups, again, typically primary care clinicians or practices, using a video web-based platform to bring case-based learning into the ECHO sessions and really build the competence and confidence of the participating spokes. So in this, I know we use hub and spoke in lots of different ways, and we're in New Hampshire that now has its own hub and spoke model for opioids, and next door to Vermont that has its own model for hub and spoke for opioids. This was actually used hub and spoke before actually the opioid language ever adopted it. But again, specialty hubs with primary care are now maybe community-based spokes. Go ahead. And being committed to using data as well. Some people hear this and say, well, isn't that telemedicine? Aren't we doing it already? And the answer is really no. So telemedicine traditionally, right, is using remote connections between single specialists and single clinicians, maybe primary care clinicians, or even patients directly, to impart specialty knowledge, right, to benefit from the specialty and expertise of individual specialist physicians. The ECHO model is a many-to-many model, really bringing together several specialists with multiple, again, primary care clinicians or other groups to really spread that information and knowledge out to many. Go ahead. And you can see here a little bit more about the differences, right? So it's not, ECHO is not direct service delivery. It's really the leaders of the model and the movement are very quite clear that it's not a direct clinical consultation. It really is an educational opportunity that brings multidisciplinary teams, ideally together with specialists. It's typically not a billable service because you're not providing a direct service to clinicians, to patients, but you're building, again, the capacity and confidence and the skill and knowledge of ideally community clinicians, maybe often rural clinicians, to be able to manage more challenging conditions that they otherwise might not be feel comfortable to do. And ideally also promotes a multi-directional flow of knowledge. So it's not just specialists, imparting their knowledge to primary care clinicians, but conversations going both ways and among the primary care clinicians as well as with the specialists in that specialty hub. Go ahead. You can see here some of the original data. So when Dr. Aurora from University of Mexico first started this, it was around the condition of hepatitis C, and he often tells the story that there he was in rural New Mexico and realized that he had a whole waiting list of hundreds of patients waiting to see him for hep C. This is in the early days of treatment, and thought, why are we doing this? Why are we making patients travel many miles and waiting many weeks or even months to see me when I could train the clinicians out in the community to adequately take care of these patients? And so when in the early days of using the ECHO model, they did a rigorous study looking at the outcomes of treatment for hepatitis C when provided by primary care clinicians who had been through the ECHO model. And they showed over time that outcomes from patients who were treated by primary care clinicians who had been through this model were as good, if not better, actually, than the care provided by specialists. Go ahead. From there, the model has really expanded to many, many, many conditions and many, many, many communities around this country and around the globe. And I think that's because it really offers a lot of opportunities for health systems. And again, we think particularly rural communities to improve quality, ideally control cost, and be more responsive to the needs of patients and communities. So really has proven to be a great way to improve quality and safety, to disseminate knowledge and best practices. I often say also in this era where we've had the divorce between inpatient and outpatient clinicians, right? I'm old enough that I remember the days when you, as a clinician, walked into a hospital and went to the doctor's lounge and got to see your specialist clinicians, your specialist peers, and could do the old curbside consult or have a conversation, or you all went to grand rounds together, right? But sometime around the, probably the 90s to early 2000s, we had a bit of a divorce between inpatient and outpatient medicine, right? With the advent of the hospitalist movement, which had certainly many of its own strengths. But one of the inadvertent results, I think, was that it meant that we as ambulatory clinicians really didn't go in the hospital that much anymore and didn't see our specialist colleagues. And I think it's not unusual now, at least in our community here in Maine, to have communities where the primary care clinicians have never even met some of the specialists, never mind have an ongoing relationship and access to readily ask them questions or do that exchange of learning. So I think that's another key benefit of the ECHO model, is kind of rebuild those relationships and those opportunities for learning, which I think very much can contribute to professional satisfaction. We often hear clinicians who participate in ECHO sessions say it's one of the most enjoyable parts of their week or their month. And then again, for patients, if those primary care clinicians are able to provide care for complicated conditions, be it hep C or HIV or complicated diabetes or substance use disorder, that's a real service to the patients in that community as well, who don't have to travel maybe those many miles to see a specialist. Go ahead. Through the generous funding of HRSA, Quality Counts, which had really been looking for opportunities to get involved in this ECHO movement, was able to get funding a few years ago to create what we now call the Northern New England ECHO Hub. You can see here that we are one of actually many ECHO hubs. So there's a whole process now to become an ECHO replication site. You sign up with the University of New Mexico's ECHO Institute. You do intensive training for staff. You agree to a whole bunch of ways in which you adhere to the ECHO model and maintain the fidelity of the model. And then run one or more ECHO programs. So you can see there are actually several ECHO hubs across New England, of which we at Quality Counts run one in partnership with folks like Jeanne at the Citizens Health Initiative out of UNH and the Vermont Program for Quality Healthcare in Vermont. And at the same time, you can see others, including Dartmouth Hitchcock, have their own ECHO hubs. Go ahead. And again, we think Northern New England is a great place to be doing this given the rural nature. These are the additional partners in our Northern New England Echo network. I won't read them all, go ahead. But I should point out the AHECs, the Area Health Education Centers, are important partners across the 3 New England states as well. You can see the mission and the vision for this, really to bring Echo out more widely into rural Northern New England. Go ahead. And with the goals of improving knowledge and support for primary care practice teams across Northern New England in order to improve and sustain the capacity of high quality healthcare across Northern New England. Go ahead. And this is what it looks like on an Echo session, very much like what you're doing right now. So most Echo programs use the Zoom platform, and you get what we call the Brady Bunch view. For those of you who are old enough to remember Brady Bunch, I realize now so many of the analogies and examples I use, young folk don't even know what I'm talking about, but those who remember the Brady Bunch will remember this little screen, and that's what it looks like during an Echo session. You can see down in the lower right-hand corner, that's what the in our case, our faculty team or specialty hub looks like, and then we're connected through a web-based video connection with a whole series of folks out in the community, perhaps some of the specialists as well, participating remotely as well. Go ahead. So from that, we thought that the Echo model was a great way to bring extra training to address the opioid epidemic for a lot of reasons, and I'm going to hand this over to Jeanne Ryer to take it for this section.
Great, thanks Lisa, and I'm really sorry I'm not with you in person. I actually started out and turned around, and I'm pretty intrepid. I used to commute to Lebanon every day, but today was not a good day to try it. And Alan, thanks for the introduction. I'll fill you in on the sources of all my degrees. I have the ultimate New Hampshire trifecta of institutions. I got my bachelor's from the University of New Hampshire, which is now my work home again. My master's from what used to be called CECS, but is now called TDI at Dartmouth. And then the Doctor of Education from New Hampshire's best university for teaching about how people learn and how to teach both adults and kids, Plymouth State University. So I've got 2 shades of green and 1 shade of blue in my academic resume. I know we're all too familiar with this graph and with this trajectory in the many ways that it's shown, the 3 waves in the increase of opiate use disorder and opiate overdose deaths. Next slide. And we also see and know all too well the trajectory here in our states. And New Hampshire unfortunately claims the top spot in overdose deaths. We seem to have leveled off in part due to some aggressive distribution of Narcan, naloxone across the state. And I don't think there's anybody in our state whose family or any community who has not been touched by one or many of the people represented as deaths in this graph. So next slide. I want to talk a little bit about the challenges and gaps in both of our states. The main information is supplied by Lisa, so she can catch me up if I get something wrong. But Maine's challenges include really few cross-sector community efforts focused on decreasing overdose deaths. There's a lack of rapid or immediate access to treatment in most communities in Maine. Lots of barriers to accessing existing MAT programs, and those barriers are often unrecognized. And by the way, they're going to be consistent themes across our states. Vermont is a little different, as we all know. They're kind of got ahead of things, got ahead of the curve. We also don't see in Maine a consistent approach for offering treatment to really high-risk populations, people recently incarcerated, homeless, or who had prior overdoses. And Maine is particularly challenged by efforts to make naloxone widely available, but I'm confident that that's about to change with energy that Dr. Letourneau and changes in state policy will probably bring to bear. Next slide. So the approach in Maine, and I would say it's becoming similar in New Hampshire, is to build a comprehensive approach. Harm reduction, education, prevention, treatment for those who have OUD, and then law enforcement efforts to address supply. Next slide. And there's a consistent spectrum of action for clinicians to promote efforts to prevent addiction, to decrease opioid prescribing and improve the safety of that prescribing, improve chronic pain management. I think the Caring for Maine effort that Maine Quality Counts and Dr. Letourneau have done has been exceptional in that. Screen for and recognize addiction where it exists, offer MAT, and promote rescue and harm reduction strategies. Next slide. ECHO is a perfect model to help us address the opioid epidemic in our rural communities. It's a key strategy to create opportunities for healthcare partners and communities to build their expertise, using distance learning to overcome the challenges in very rural geographies as we all understand them, expand opportunities to engage providers in really rural locations where there's difficult to build services for opioid response, and connecting communities statewide to best practices to support and sustain their work and convene them to share the best practices to reduce drug overdose deaths. Next. So the Northern New England ECHO network has 4 ECHOs sessions in under its belt or in process right now. In fact, one of them is going on as we speak. The Older Adults Care ECHO is holding its ECHO session at right now on a different Zoom platform. Our first effort was an ECHO on community-based care for perinatal substance use disorder. That ran into the fall. The medications for addiction treatment ECHO began in the fall and is ongoing now. And the new community opioid overdose response ECHO is also ongoing in Maine. So the perinatal SUD ECHO was for Maine, New Hampshire, and Vermont, as is the older adult care ECHO. Medications for addiction treatment is focused on New Hampshire and Maine, and community opioid overdose response is focused on Maine alone. Next. So you can see the communities we've reached from the very top of Maine and Aroostook County, all the way to southern, southeastern Vermont in the ECHOs related to substance use disorder and opiate use disorder. Next. So why is Project ECHO a good approach for improving our opiate response? First of all, it supports community-based providers. It develops with them and for them a professional learning community. You can hear my ed school background kind of coming in here. It promotes knowledge exchange. It provides them case-based distance learning. And of course, especially for clinical providers, case-based learning, the kind of grand rounds format is really familiar to people and makes a lot of sense to them, and it's also very effective. And Project ECHO is evidence-based. Next. There's an extensive bibliography on all of the papers, peer-reviewed and otherwise, on Project ECHO on their website. We've put together a resource list for you that'll give you a link to that. Just a couple of highlights in addition to the study that Sanjeev Ryer did on hepatitis C. New Mexico, this is from a study Miriam Comaroni did, looking at the use of ECHO in New Mexico to increase the number of buprenorphine waivered physicians starting from 2005 to 2014. The time frame here is important because, of course, New Mexico got hit with this a lot earlier than we did. And ECHO was really effective in increasing the number of waivered providers in a very rural state with traditionally difficult to serve populations. Next. We've also seen some excellent research on the efficacy of ECHO and its effectiveness. It's a study by Anderson and colleagues who pretty much prove out what we see working in ECHO is that ECHO increases provider knowledge. It increases provider self-efficacy in terms of how they feel about using their knowledge. And so what that boils down to for us, or the words that we tend to use, is that it increases both provider confidence and competence particularly in an area like MAT. So we are excited to say that in addition to participating in the Northern New England Echo Hub, the University of New Hampshire is starting its own Echo Hub as part of the UNH Telepractice Center. UNH is going to be preparing students for telehealth practice across all the disciplines that we teach, which includes nursing, nurse practitioners, occupational therapy, communication sciences and disorders, social work, etc. We started something called the Partnership for Academic Clinical Telepractice, and those are going to be partnerships between community clinical sites and academic programs. We're going to have 2 Project Echo sites at the university, one at the UNH Law Campus in Concord, which is where our offices are, and one at the main Durham campus in the College of Health and Human Services. Next. So the first, given the topic of the day, but also the topic of the day every day in New Hampshire right now, the first UNH Echo session is going to be on medications for addiction treatment. We recognize that there's a considerable amount of unmet need, that certainly even just the first MAT Echo from the Northern New England Network filled up really rapidly. And we are now enrolling community practices for an April start. This is going to be really consistent with the philosophy of the Northern New England Echo. It's going to provide case-based distance learning for community providers. It's also going to support clinical MAT curriculum for our nurse practitioner, graduate and postgraduate students, and community practice provider sites. And something new for Echo is that I think we're the first program in the country and probably in the world that's integrating Echo into our graduate nurse practitioner curriculum. We expect, and thanks to SAMHSA funding for this, that we'll be graduating 50 nurse practitioner, master's level nurse practitioners and postmasters nurse practitioners with Psych NP certificates who will be already waivered or able to get waivered right at graduation or right after. So we're excited to be expanding the Echo model in that direction. Next. So the problem in New Hampshire, and one of the reasons why we looked to Echo first for our very first Echo session, is limited access to medications for addiction treatment. Certainly, we are not sure that, unlike New Mexico in 2005, we're not sure that we actually have a provider shortage for waivered providers, because we have 250 to 300 trained and waivered prescribers in New Hampshire based on the SAMHSA website. But we still do have a gap in provider availability. It's a little hard to pin down what that gap is, and the state is addressing some data resources to try and understand it. But we know that most of those 250 to 300 providers are not caring for a significant number of OUD patients. Very, very few would be working to the limits of whatever their waiver, the number of their waiver allows. And we also know that many prescribers in New Hampshire have yet to write their first prescription, which means they don't yet have a lot of experience in actually providing OUD treatment through MAT. We have the same barriers to MAT that probably everyone does, stigma being the first one. There's a stigma on the provider side or in practices that people we just don't want to deal with, quote unquote, those people. There are barriers, there's stigma in, I think, some of the recovery community, though that seems to be reducing. There's travel barriers, there's payment barriers, there's all kinds of barriers to access to MAT. Next. So New Hampshire, I think, has been making great progress in developing a system of care similar to the chart we saw earlier, where we have developed and funded, the state has funded a community practice with state guidelines, in-person and phone session support for prescribers. They have funded a statewide physician data waiver trainings that have been free and with CMA accompanying them. The state has made grants to health systems to add MAT to their practices, both for safety net providers and critical access hospital systems. We have our new hub and spoke system, which is not exactly like the Vermont hub and spoke system, and it is now called the Doorway. And that new system, which is stood up January 1st, and so they're rapidly getting underway, has a new requirement to offer evidence-based treatment, including MAT. We have our own efforts to bring Project ECHO into and make it available for providers and prescribers. And we also have had widespread naloxone distribution through multiple channels, public health, standing orders at pharmacies, and it is certainly helped, I think, flatten out the overdose death rate that we have been experiencing for the last few years. Next. So the goal for the NNE ECHO on MAT and is really similar to the goals and the basic philosophy that we're going to carry over also into the UNH MAT ECHO, to improve the lives of patients and families living with substance use disorder, enhance the capacity and quality of services available to patients in their own communities through their local primary care practices. I think key to all of our philosophy is establishing a culture that understands addiction as a chronic disease and treats it as a chronic disease, and being able to address a range of issues, including comorbidities, underlying trauma, mental health conditions, and often other social determinants of health. We are also looking to identify strategies and best practices, resources, and emerging topics. One of the underlying philosophies of the Northern New England ECHO, and again will be carried forward into the UNH ECHO Hub, is an approach that focuses on interdisciplinary team-based care with strong connections to the community and a strong sense of a patient-centered approach. So every one of our ECHOs so far has had a multidisciplinary team with a range of types of providers, and also has included a representative patient voice, usually through peer recovery or other community-based support providers. So the first MAT ECHO for Northern New England has a whopping 99 spokes. This is above the recommended daily allowance, by the way, from ECHO. It has the fearless Dr. Lisa Letourneau as facilitator, and she manages to keep the trains running on time with those 26 site locations, pretty much evenly divided between our two states. And it includes, again, look at this interdisciplinary approach: primary care providers of all varieties, nurses, behavioral health, medical assistants, system leaders, CEOs, and other folks in supporting CAS in all of these organizations. So we try to walk, this is a philosophy both of our organizations have shared from the beginning, that if we're going to go for system transformation, this is the way you do it. You don't do it in silos. And I think, once again, we are trying to walk our talk, and I think we do it fairly successfully. Next. Every ECHO, so let me tell you a little bit about the anatomy of an ECHO session. So every ECHO begins with a 10-minute didactic presentation on one area of focus for the topic. And then every ECHO then has a case presentation from the community spoke provider. So primary care provider out in somewhere in our universe presents a case that's troubling them that they want to share. It's a real-time case. It's not a made-up case. And we often will bump cases up to the top of the queue if somebody really needs kind of urgent consultation from their peers in this network. They present the case. The community providers comment on the case and ask for clarification. The faculty experts comment on the case and ask for clarification, and then each group in turn provides its recommendations. I will note that the ECHO philosophy is that the community spoke providers always go first, and the faculty always go second. So the didactic for the first MAT ECHO includes understanding addiction, again, as a chronic condition. It uses the SAMHSA Tip 63 as its kind of guiding principles and protocols, promotes recovery and support. We've had a session on when and how to do urine drug screening. We'll be working on office practice flow, managing pain in patients being treated for SUD and OUD, managing high-risk special populations, and addressing risk of drug overdose in MAT patients. So I think the biggest challenge for any ECHO so far that I've seen is getting our faculty experts to be able to do one of their didactics in only 10 minutes. Usually they have about 50 slides. We have to get them to boil it down. Next. So far, the evaluation for the MAT ECHO is very positive. Again, consistent with ECHO evaluations elsewhere. We're getting really good marks on the usefulness of the didactic sessions. People feel they're enhancing their competence and that they're having a positive influence on their practice. They're considered that the case presentation is really excellent or good and is enhancing their competence. So again, if you look on those two right-hand little dials, those are the two things I was talking about earlier. Confidence and competence, so are being enhanced here. Next slide. The results from the perinatal substance use disorder ECHO were very similar. Enhanced knowledge was high. The quality of the information was excellent or good. Positive influence on knowledge was good. Enhanced competence and resulting from the case presentations. Next. And as I noted, those are pretty consistent with ECHO evaluations done on other topics and on MAT as well. So the challenges, some of the challenges remaining are coordinating existing efforts to engage clinicians in OUD response across the tri-state region. We are working hard to engage practice leaders in covering time for clinicians to participate in ECHO. One of the biggest barriers that we have right now is the tyranny of the RVU, and even carving out time for a lunchtime continuing ed session gets more and more difficult. We also are, as we have said, our philosophy is to coordinate clinical efforts with community responses. Opportunities for ECHO are, again, building that confidence and competence of physicians in an area in which many have little experience, and some maybe have their waivers, but they haven't yet provided any care for a number of reasons. And then we really do need to figure out a systems approach to connect clinicians with community partners. I think the New Hampshire hub and spoke doorway system is really working for that, and I think that will, New Hampshire and Maine have much to learn from each other, and I think our organizations are really committed to building that kind of regional partnership, as we have been for some time. So Lisa, I took some of your slides.
That's quite all right. You just got to roll there. So awesome. So we have had such, I think, been so pleased with the way the ECHO programs have gone that we look for other opportunities to sort of stretch the model a bit, as actually the folks from New Mexico would encourage us and others to do. And one of the challenges that Jeanne cited early on in talking about the opioid epidemic that I feel strongly about is that we have got to break through our silos, right? That it's great more clinicians are doing this work and that we have more folks offering medications for addiction treatment. It's great that some ERs are starting to offer buprenorphine for opioid use disorders. Great that we have some innovative police and correction systems programs. But unless we're talking to each other, it becomes very hard to address the issue in a community. So we took that idea and said, geez, could we use ECHO to try to break through some of those silos and connect the dots within communities and use the model to really stretch it from just the traditional specialty clinician to primary care clinician to interdisciplinary set of specialty experts on opioid use disorder and what it means in communities to bring it out to communities for a multi-sector approach. So we did that, and we decided to try that and look to similar kinds of efforts, not necessarily using the ECHO model, but similar cross-sector efforts in initiatives like the Project Lazarus program, which folks might have heard about in Wilkes County, North Carolina, which was a particularly high hit area in terms of drug overdose deaths, as well as now a similar effort in something called the California Opioid Safety Coalitions Network. So both of those, go ahead, are initiatives that really look to community-based efforts to address the opioid epidemic. And we do know from looking at data from other states that there are starting to be decreases in overdose deaths, at least this was 2016 to 17 in several states, including Massachusetts, Rhode Island, Washington, California. And many of those have community-based efforts. Interestingly, Jeanne, you've probably seen the 2017 data showed the New Hampshire rate go down, and sadly, Maine is now above Rhode Island and Massachusetts, as those have either held steady or gone down, and we're now closing in on New Hampshire as we've gone up and you've come down just a little bit. So still an incredible need. Go ahead. So again, we've looked to other efforts such as the Project Lazarus model in North Carolina, where they again use hub and spoke in a different way. It has to be the most popular term, right? So they said, well, geez, if we could have a hub of common purpose, including increasing public awareness about the risk of opioids, acting together through community coalitions and using data to drive this, then let's try to use that to connect our spokes of community providers, education, hospital, harm reduction kinds of initiatives, et cetera, to bring those sectors together. And they have shown impressive decreases in opioid overdose deaths in that community. Go ahead. And then I mentioned in California, a similar opioid safety coalitions network, a little bit hard to see some of the print here. If you blow it up, it says similar things, basically working across folks like law enforcement and school, public health, clinicians, to have people working together within local communities to address this epidemic, understand who's dying, where are they dying, what, what's in their system at the time, what kind of treatment have they got, did they just get released from jail, are they in treatment or not, right? So until, again, these sectors are talking to each other, I think it's going to be very hard to address this in our communities. Go ahead. So that's what we did with the Core Echo. We said, okay, communities, and we knew there were a whole bunch of community coalitions across the state that were working on different aspects of health, and now at least many that were working on the opioid epidemic. So we said, okay, you existing coalitions for the most part, but if you want to create a new one, you can do that. If you can bring together at least, we said 4 to 6 of these sectors: public health, healthcare, behavioral health, substance use treatment providers, EDs, recovery community, law enforcement, EMS, schools, etc., then let's see if you are interested in working through our core, again, Community Opioid Overdose Response Echo, to learn about how do you work as a community. So we put the call out, go ahead, and we happily got even more folks who we could accept into this program. We also recognize that to do this, because it's one thing if you're running a traditional echo and you say, okay, we've got this hub of specialty experts and okay, primary care practices, who wants to participate? In this case, we thought, well, we need communities to participate, but there's got to be some kind of convener, right? They don't just magically come together. So again, we put the invite out largely to existing community coalitions, and we said, if there's an entity who is the convener of this coalition, then we are happy to provide a small stipend. And we're doing this under the Northern New England Practice Transformation Network role that we have, that again, New Hampshire and Vermont participate with us. So a CMS contract to try to support practice change, but also address the opioid epidemic. So we provide the community coalitions with a very modest stipend to serve as the convener within that community, to assemble that multidisciplinary cross-sector community spoke team, to help organize, get people to the meetings, host the actual ECHO meeting, and kind of be the nidus for our of that activity and our connection within the community. Go ahead. So we got, I think, something like 16 or 20 applicants. We accepted 12, although we said to the rest, if you want to participate, we don't have enough funds to provide a stipend to more than 12, but others can participate. And again, just use the ECHO model, but in this case, instead of having purely physician specialists in the hub, we have people from the recovery community, the harm reduction community, clinicians, ED clinicians, police chief. We actually got Fred Brayson, who's the executive director of the Project Lazarus project in North Carolina, to be on our faculty. And then again, we have the community coalitions, which are far more than the 5 you see here, but just showing kind of how the model extends. Go ahead. The didactic topics, just like Jeanne went through them for the MAT echo, we said to our faculty and communities, what are the big issues you're dealing with as communities, and how do we address those? So in a similar way to the traditional echo, we start out our core echo sessions with a 10-minute didactic topic, educational session on one of these topics, and you can see the various topics here. You know, I think the list could be much longer than this as well. It's always the challenge of which ones do you pick and how do you do it in 10 minutes, but so far it's been going great. Similarly to again, the more traditional clinical echo, we have each of the communities bring a case each time. So 10-minute didactic and then a case. We have a 90-minute session and we do one case, and we ask the community to bring whatever the challenge is. So it's not so much, you know, how do I deal with this patient? It's how do I deal with this issue? And some of the issues so far have been, geez, in our community, we started offering buprenorphine in the emergency department, but it seems hard to get people motivated to participate. You know, when they're coming in for the overdose, we thought they'd want to participate in treatment, but it turns out a lot of them don't. So how do we address that? Another one was how do we connect the dots within our communities? Actually, it's a community that's done tremendous work. They came to us with a hotspot map of where their actual overdoses were by, you know, street in their community, which was just astounding and something the other communities, I think, really got them interested. And they said, geez, we've got a lot of work, but how do we really focus this and connect the dots? The last one was about prevention. How do we get more prevention efforts out into the community? Working with schools. So just fascinating cases, great discussions. Go ahead. We do ask them to actually focus on 4 areas primarily, and that is data, who's dying in their communities, rapid access to treatment, getting out naloxone, and connection with the recovery community. But within that, you know, there's lots of opportunity for bringing different issues. So I think that's it from us. We certainly have time for questions, thoughts.
And while we're waiting for people to pop up with questions, first of all, you can ask them in the chat or unmute yourself and ask us. But while you're thinking about what you might want to ask, I'll put in a plug. We're recruiting for the UNH MAT Echo. We have only 18 spots. So if you're interested in that, the priority is going to go to rural and underserved communities, practices with waivered nurse practitioner prescribers. But I've provided the CTN team with a list of the references for this presentation, the resource links for both the Northern New England Echo, Project Echo nationally, and also a link to the enrollment form for the latest Echo. So who's got questions for us?
Hi, can you guys hear? I have to thank you for that wonderful presentation. I'm wondering if you could speak a bit to the cost of the Project Echo, and if there are costs to a community partner. And sort of, yeah, I guess speaking to what does it take to become a Project Echo partner, and what are the costs, and where does is there data collection, and where does the data go?
Lisa, you want to start, and then I'll.
Sure. So the cost probably depends on, you know, which role you're talking about. So if you want to be a formal Echo replication hub, like we are serving, you know, and running our Echo programs, then there actually is no cost to get that sort of, you know, designation from University of New Mexico, other than you need to go there and go through their replication program. So it's the cost of getting staff there and, you know, time to go through it, but there's no like licensing fee. You just have to commit to doing it the way, you know, in accordance with their model. And then of course, then to host Echo sessions, there's the cost of staff time really to do that. Zoom is very inexpensive. I don't know, a couple $100 a year or something. And then whatever technology, but we almost all have cameras and that sort of thing. You really don't need more than that. In terms of the cost of somebody participating in an Echo, it's really time. So again, provider time is the biggest issue. And again, in this ridiculously, you know, crazy fee for service payment system that we're still in. Unfortunately, it's provider time away from seeing patients, unless you can make the argument that, it will increase their, retention, professional satisfaction, maybe productivity in the long run. But somebody's got to, be willing to put that investment in. In terms of data, do you want to talk about that, Jeanne? Or
Sure. I think the cost of being an echo hub or running the kinds of echoes that Maine Quality Counts is already doing and that we will be doing, it's really predominantly driven by staff time. Again, a modest amount for equipment. The Echo Institute will actually give a hub the Zoom licenses that they need and the box file sharing licenses as well. So there's some you need a little bit better hardware, not a lot. Certainly not the $20,000 telemedicine installations that we used to see. It's more like a nicer camera and microphone than you might typically have in your laptop. But staff time is the biggest expense. We also try to pay modest stipends to our faculty experts, but they're definitely not getting rich on this for sure. ECHO has a principle that the participating community sites do not pay. It's not a subscription model. So you have to have sponsorship either from an organization, from a foundation, or some kind of institution. Data collection is a dance that we have to walk very carefully. We're all evaluators and researchers at heart, and we would love to extract all kinds of data from our participating practices on their outcomes. But the challenge is that, of course, they work for many different institutions. They have multiple kinds of EHRs, and they may or may not be able to get organizational buy-in to supplying that level of data. So we have to be really light on our collection of evaluation data, but we do try to collect some basics. And then I think there's another question in the chat. Is there a chance that you'll be repeating the module focused on PAT? I'm not sure which acronym that was. And again,
I bet they meant MAT.
MAT. So we have the new one for New Hampshire. I think I don't know about Maine, Lisa, but I've said publicly that I think New Hampshire probably needs perhaps 2 to 3 MAT echoes on different days and times of the week, and perhaps focused on different types of providers. So I think we will be looking at that. And as for the core echo, will you be offering that again in Maine, Lisa? And I wonder if that's something we should think about trying to do in New Hampshire in conjunction with the new hub and spoke doorway.
Yeah, so we don't have a plan at the moment, but honestly, it's gone so well that I would love to do it. I think there's obviously, a continued need. It's really a funding thing. So right now, the core echo, the staff time comes out of the NNEPTN. That contract goes through the end of September. I'm hopeful that, we will have other ways to fund things like this. Our state, as you all probably know, just had a giant change in the mindset of the administration, and so I'm hopeful that there will be more interest coming out of the state administration as well. I think the questioner, the commenter just clarified that we meant perinatal echo for PAT. Again, we don't have a plan on that one right now. I do think it's a huge need. I will say one of the challenges with the perinatal echo, though, was that it was hard to get the right providers on, right? So it was about sort of the perinatal period, substance use disorder, and it was a mix of folks, but not necessarily prescribing clinicians. So that was a little bit of a challenge, and that's tough because OBGYNs trying to get them on things like echo sessions. It's just hard. So I would say there's a huge need, and I think if we can get the funding for this, we certainly would be interested in doing more.
Yeah, so Daisy Goodman and Julie Frew were on the faculty for that perinatal SUD echo, which was great to have them. They certainly, their whole philosophy was really consistent with everything that we are always trying to make happen. The big challenge with echo is getting the hunks of resources to cover the staff time to stand it up and keep it running. And so that's something we all need to do. And if you're in a position to advocate for funding for echoes, please feel free to do so. We certainly aren't at a point of peak echo yet. I mean, we're not at saturation. I think we we could be offering more and be targeting more. And we're really looking forward to, we know that Dartmouth-Hitchcock is working on standing up an Echo Hub, and we're really looking forward to them joining us in Echo Land. One of the key principles of Echo is it's not a franchise, and we're all bound by our agreement with the Echo Institute is that we support the spread of Echo and more hubs and not fewer. So,
how often do your community hubs meet?
So there's a variation, and I think one of the things the literature doesn't really help us with enough yet is what's the right dose of Echo to get the right amount of change. So Dr. Aurora's Hep C Echo has been going every week for 2 hours a week for multiple years, more than 10. Actually, well more than 10, probably 15 years. We are challenged by getting that provider time. So we've done ours, we are using a cohort model in the NNE Echo, and usually going for 9 or 10 months for an hour to an hour and a half a month. Is that enough? I think we would like more, but that's what we can get people to feel like they can commit to on the provider side. I would also like if people could chat in ideas. We're doing Echo planning at UNH, and I know NNE Echo is as well. If you could chat in your ideas for topics that you think would be really compelling and necessary, and where an Echo might be really useful. The kind of key formula for Echo is it needs to be a complex but common condition that could be treated better either in community primary care or in the new core model where a community is working on something. And I see a chat from Mary Ivanovsky, and hi Mary, I saw you out there. And yeah, we are really excited, and of course we're all willing to help Dartmouth-Hitchcock get launched on their Echo. Hi there. So what are ideas you have for topics? I bet Mary would like to know this at Dartmouth-Hitchcock, and Lisa as well. If you have any ideas for, areas, especially in the substance use disorder field, I think, Alan, going back to the topic that you mentioned for the next session on methamphetamines, meth is roaring back in New Hampshire. And though I'm not sure we have a consistent way to treat yet that Echo would be supporting, I think that might, I don't know when we would be ready for something on methamphetamines. What other topics in this sphere do you think would be important?
This is Alan. I don't have a topic for you, but I was wondering if in the context of the Echo sessions going on, do you get a lot of distraction or people wanting to talk about related or ancillary things or other drugs when it's an opioid focused Echo?
Well, I'm going to let Lisa answer that because she's a prescribing clinician, but I think what I see as a systems level observer is a lot of co-occurring disorders and social determinants of health. Lisa?
Yeah, I mean, it's certainly issues of other drug use come up, but that's a valid part of the discussion, right? What do you do when you're treating somebody with MAT and they continue to use cocaine or meth or whatever, right? So that, yes, comes up and is appropriate. I wouldn't say we've had too much in terms of distraction, and it's been, maybe a little bit on our MAT Echo. Jeanne, you probably heard on sort of alternative stuff and herbal stuff that may or may not. I mean, the tough part is you need to stick to an evidence-based discussion. So people start talking about things that don't have that strong an evidence base. It's appropriate to question that, but it hasn't really been a distraction. So I think it's been great.
A couple of themes I've heard. First of all, trauma, of course, trauma. And also traumatic brain injury has been a kind of an undercurrent in a lot of the cases. We have been fortunate in that we have pharmacologist who specializes in addiction and psychiatric medications, and she has been a huge and wonderful addition to both the perinatal SUD echo and to the MAT echo in helping tease apart, subclinical doses and things that might be making things worse instead of better. Lisa, I think she's been a great addition.
Amazing, yeah. That's Stephanie Nichols. We'll do a shout out. Who's with Hudson College and UNE and Maine Med. And boy, if anyone is thinking about running an echo that has anything to do with medications, which is probably most of them, in some way, strongly urge you to think about bringing a clinical pharmacologist on board because she is unbelievable. It's great.
Well, I know we're running out of time.
Yeah, I think we're over.
We are about out of time. So anybody that has any ideas for echoes, I'm sure we have their contact information around, and we know how to reach both Lisa and Jeanne. And Lisa and Jeanne, I want to thank you very much, not just for today's presentation, but for all the remarkable work and time you put into trying to train the community. We have an implementation core to our CTBH center here and the CTN, and we talk a lot about implementation, but we're always struggling to find good examples, et cetera. This is all about implementation, and it's a wonderful model. Collecting the data, not so easy, but obviously you're reaching lots of people, and there's lots of effort going behind it. So anybody has any good ideas for funding these types of programs, send those along as well. And again, thank you very much for your time.
Goodbye, everybody. Thank you.
Thank you.